Good morning, good afternoon, good evening, wherever it is where you are. Welcome to Professor M Explains. Today we're going to be covering a topic specifically for the PTAs or physical therapist assistant dealing with the NPTE or their national practice exam. We're going to talk about motor neuron damage or disorders as it focuses on upper motor neuron versus lower motor neuron presentation. So with that, let's get started. So how can these neurons suffer damage, right? The motor neurons are the neurons that are going to provide innervation to our skeletal muscle, anything that basically has to move in the body. So how can they suffer damage? Well, they can be damaged in numerous ways. Spinal muscular atrophy, progressive muscular atrophy, gene mutation, primary lateral sclerosis, PLS, or ALS, amyotrophic lateral sclerosis, which is also known as Lou Gehrig's disease. Kennedy disease or BSMA. Physical trauma can also cause it, something like a spinal cord injury or a CNS insult. Viral insults also can cause this. It was pretty common in post-polio, and herpes simplex viruses are very common for attacking the CNS. Of course, there can also just be idiopathic damage, meaning we don't know where the damage came from. All of that's going to cause the patient to present in a very specific way, depending upon if they are specifically upper motor neuron involved or lower motor neuron involved. So how do they present? Well, let's talk about upper motor neurons and lower motor neuron injuries. So they're going to present with very specific symptoms, right? And how do you tell typically where these occur? Well, the upper motor neuron injury is going to occur before or above the level of the anterior horn cell, whereas lower motor neuron injuries will occur after or be below that level of the anterior horn cell. Right? So we're talking about that ventral or that anterior root coming off the spinal cord. If they're an upper motor neuron injury, what do they look like? Well, they look like this. They often present with hyperreflexia, meaning they're very hyperactive reflexes. They'll have increased deep tendon reflexes, so they'll have very, very rapid and brisk responses to testing things such as the patellar tendon reflex or the Achilles tendon reflex. They'll have a positive Babinski sign, meaning when you test their foot, their toes will often splay into extension and flay outwards. They'll have a positive Hoffman sign. When you flick that third digit, oftentimes you'll notice reflexive movement in the first and second digits. They'll often present with clonus, meaning when they start moving, they have rapid motions they can't stop. And the clasp knife reflex will often be present in these patients. As far as muscular atrophy goes, they're typically going to have disuse muscular atrophy because they're going to become frustrated with that limb. They're going to stop using it. So it's not going to waste away. It's just going to stop being used. Fasciculations and fibrillations are going to be absent in these patients. Their tone is going to be very hypertonic to spastic. And when you have that, it's often going to develop into eventual spastic paralysis. And the interesting thing about this is it is velocity dependent, meaning the faster you try to move that limb or the faster you try to stretch that limb, the more the spasticity is going to kick in. So you have to be very slow and low in any movements you do with that. If the bladder is involved, it's often going to be hypertonic, sometimes spastic. They'll often be able to void, but they'll have difficulty voiding fully. So it'll lead to feelings of uncomfortableness and just doesn't feel like they're completely emptying their bladder. They'll have loss of autonomic control oftentimes, especially dealing with upper cervical or upper thoracic injuries, and they may present with possible pronator drift in the upper extremities. The weakness will present very irregularly. In these patients, if it's in the upper extremities, the extensors are often more involved than the flexors. If it's in the lower extremities, it's often the opposite, where the flexors are more involved than the extensors. With lower motor neuron injuries, we typically switch and go to the opposite side of things. So they'll present with hyperreflexia or almost absent reflexes, where they'll have no deep tendon reflexes. Babinski will be negative, it'll be absent, or you'll end up with a flexion or reflexive curling of the toes. Clasp knife reflex will be absent as well. They will present with severe focal wasting, meaning that they'll have neurogenic muscle atrophy. The muscle will, because it's stopped receiving any signal, it will just completely waste away to nothing. There may be fasciculations and fibrillations present. So you'll get that kind of that quivering, shaking feeling when they're not actually actively trying to contract. The muscles themselves will be hypotonic to flaccid. and it'll often lead to flaccid paralysis, where that limb just kind of hangs like a limp wet noodle. The bladder, when it's involved, becomes just like the rest of the muscles. It'll become hypotonic to flaccid. That means the patient can't void when they need to. The bladder will just completely fill, and they don't have that ability then to empty the bladder voluntarily. The neat thing, or not the neat thing, but the unique thing about lower motor neuron injuries is it's often seen in post-polio myelitis. So again, we don't see that as frequently anymore because we have the polio vaccine and we had eradicated polio. But the good news is it's on the comeback. So what can we do for testing? Well, oftentimes we'll do EMGs or electromyography or nerve conduction velocity testing. This can be really useful to diagnose specific lower motor neuron lesions, along with problems to the actual muscles and peripheral nerves themselves. It can also be particularly useful in differentially diagnosing lower motor neuron injury versus peripheral neuropathy. We can do certain laboratory tests, such as complete blood tests or complete blood counts, and this is mainly to check for something like protein creatine kinase, which may rule in diseases such as muscular dystrophy or Becker's disease. MRIs and CTs are really helpful. They can help us determine if there are tumors present, if there's structural defects or compression, such as in the spine, if there's any axonal shearing that might have occurred, if there's inflammation, or if there might be vascular disorders and that particular area is just not getting the proper blood flow. So remember, when treating these patients, they're going through a pretty difficult time, and they may not fully understand their problems, so compassion to them is key. Not all these diseases will present the same way. Most of the times, if they have an upper motor neuron injury, they'll present like an upper motor neuron injury. If they have a lower motor neuron injury, they'll present that way. But a disease such as ALS often presents with what's called a mixed bag. They'll have a little bit of everything in certain muscles versus other muscles. So you have to be paying attention to that. You treat what you see. And more importantly, you treat what the PT has asked you to treat in the evaluation. You want to stick to that current plan of care. And also you want to keep the PT informed on what the patient's changes have occurred. So I really hope you appreciated this video today. I hope it taught you a little bit. If you can, please don't forget to like, comment, and subscribe, along with hitting the bell notification to notify you when a new video is released or when the channel goes live. Again, this is Professor M. I want to thank you for your visit today, and you have yourself a great day.